Well, I'd like to thank the organisers for inviting me to the meeting, which I didn't know about beforehand. And also thank you for inviting me back to Oxford. I came here at the age of 18 to do biochemistry, passed the exam, but I didn't get a place at Jesus College, but I'm back. I went to, Professor Hans Krebs was a professor at biochemistry at Oxford. However, the Krebs cycle was discovered in Sheffield. He was in the department of the pharmacology, and he worked at, it was in a laboratory beneath a cinema. I actually saw him give a lecture, so it was quite interesting. Anyway, so I did biochemistry at Sheffield, followed by medicine. Whether I would have done that at Oxford or not, we don't know. We'll have to, never know. Right, so this in Time magazine shows how to live to be 100, and they're all females. This is from about 20, 25 years ago. So if we look at this is a BMJ and a more recent publication, we will see that men are more likely to die of cardiovascular disease earlier than women. And you see the blue line for men is here, and the women is the dotted line. And same with non-cardiovascular death, it's higher in men. And it's earlier, that's the point. So that's what I'm going to talk about. I was quite interested in testosterone in the late 90s, and we decided with a cardiologist at the Hallamshire in Sheffield to look at men who are having cardiac angiography, and we showed that men with stenosis, as to those men who had gone for angiography, didn't have any evidence of atherosclerosis, that testosterone levels were lower. And we've done a lot of work. We showed it's improved angina and heart failure, so we're quite famous for that, but it's not gone into the clinical practice as well as it should have. We also looked at death. So we looked at 903 men going to the Northern General Hospital in Sheffield who'd had angiography, and they'd had their testosterone levels measured. And this is bioavailable testosterone, which I'm going to explain later. This is the biologically active component. And you'll see that those men who had a normal testosterone, which at the time was above 10.4 nanomoles per litre, were living longer than these men with stenosis were living longer than those who had disease. So this was a hazard ratio of 2.2, which is pretty impressive. Seattle, this was a study of all-cause mortality, and it shows that, again, you've got a similar sort of result. You've got those with who have been treated, and you've got those who've been untreated for their high testosterone deficiency. This is the HIM study in Australia, and we have testosterone here. This is the level of testosterone in the blood, and you can see the optimum level is actually in the normal range. If you have too little or too high, you're more likely to die earlier. So there are several studies which show this, and this was our study from our diabetic population in Barnsley, because I'm based in Barnsley NHS-wise, but also University of Sheffield, and you can see, we looked at the 10.4, because this is the American cutoff, and those men who had a with diabetes, had a testosterone less than this level, were 2.02 times as hazard ratio, more likely to be dead after a 5.8-year period. This was looked at by the FDA and said this is a good study. This was all cause, and if you look at cardiovascular mortality, a cutoff of 8.4 was evident with a hazard ratio of 2.5. So this association, what does it mean? This was the Cheshire study, which I was involved with as well. Even going on for 14 years, we see that this actually persists, this factor that low testosterone is bad for you. We also treat men with prostate cancer with testosterone, making them testosterone levels very low indeed. And this came out from the American Heart Association, and it was a science advisory group of the American Heart Association, Cancer Society, Urological Association, and Oncology, saying, look, if we're treating men lower in their testosterone levels, they need optimization of primary and secondary prevention. That doesn't, again, happen in clinical practice, and this is back in the year 2010. So we're actually got a cohort of people who are making very hypogonadal, and if you look at the data, they will die more likely of their heart disease, vascular disease, than their prostate cancer. So what's the cause of all this? So this is the European Male Aging Study, and what we see here is that this is the BMI this panel, and you'll see that the BMI less than 25 is green, 25 to 29 blue, and red is a BMI over 30, obese. And you'll see that the testosterone levels are significantly lower with weight. So the more obese you are, the lower your testosterone levels. And also you have the free testosterone, which is actually going down over the years. So this is the age. So we have got a confounding factor here with total testosterone, which is not the full story of the active testosterone. You needed to measure the free or the bioavailable. And the other thing they found is if you had one or more comorbidities, your testosterone level was lower. So that's why people, if you look at the aging factor, it is only a small effect on testosterone. Is if you have a coincident comorbidity or you're obese, it really lowers the testosterone. So is that bad for you or not? So if you look at this very quickly, you'll see that as an endocrinologist, we divide it into classical hypogonadism, the testis failure, or the hypothalamic pituitary failure, or functional. But if you look at the causes of functional, it counts for most of what's going through the NHS. Type 2 diabetes, obesity, cancer, heart failure, anemia, frailty, cardiovascular disease, chronic kidney failure, chronic inflammatory disease like rheumatological disorders, respiratory disorders, COPD. How often do you see if someone with emphysema and they've got very, very atrophy of their muscles of their rib cage, osteoporosis, and low trauma factor? And also here is chronic opioid abuse. Chronic opioid use for pain, So in these patients, their testosterone level would be low. And if you treat them with testosterone, you save their marriages, you save their jobs, and you also reduce their opioid dose by about half, and there's good evidence for that. So metabolic syndrome is very common in the Western world, and it consists of sugar problems, obesity, high blood pressure, and dyslipidemia. We know that testosterone has a significant correlation with visceral adiposity, so the lower your testosterone, the greater your waist circumference, or vice versa. So what is it, chicken and egg? What comes first? Is it the obesity, or is it the testosterone? So Klinefelter, as a classical cause of hypogonadism, is associated with metabolic syndrome. And the reverse is if you've got a large tummy above 102 centimeters, then you're more likely to have a low testosterone. We looked at our diabetic population in Barnsley, and what we showed is that there was that overall, when you put everything together, 42% of men with type 2 diabetes have symptomatic. That's hypogonadism. It had been shown before, but nobody had looked at symptoms. And the red is if the testosterone is between 8 and 12, and the yellow is below 8. So it really, and the mean level is about 12.5 in a diabetic population, so it's pretty bad. And of course, testosterone deficiency is sexual dysfunction, and sexual dysfunction is the portal to men's health. Inflammation, insulin resistance, metabolic syndrome, dyslipidemia, atherosclerosis, hypertension, vascular stiffness. It's all associated with this, and we looked at insulin resistance. So we've got the obesity, type 2 diabetes, CVD, mortality. Right, so what if you give back testosterone? So we did a sub-analysis of our death study, as we call it. And if you look at it, these are the people who had low T we didn't treat in the noughties. And you can see that 1 in 5 were dead after 5.8 years. That is terrible. If you look at a diabetic who had normal T, it was still almost 1 in 10. The ones we treated, which were the worst, with the very low levels, it was 8.6. We'd reversed a death rate of 20% to what you'd expect for normal. And you can see that again. This is another study from Jeff Hackett in Birmingham, and you can see the reduction. Yellow is the treated group, and hypogonadal is untreated. And if you look at the differences, they were very significant, and it's been repeated a few times now. And if you look at outcomes of treating men, and this is very important, you need to treat back to normal. And if you don't treat back to normal, right, you don't get as much benefit. But this is all-cause death, but if you go to cardiovascular death, you will see similar. You do get benefit, but it's not as much as great as if you replace place back to normal, and that's been shown as well. So the clinical manifestations of testosterone deficiency are mainly physical, psychological, sexual, which you'll know about, and you'll see diminished libido, erectile dysfunction, difficulty achieving orgasm, and decreased performance. But it also affects people from a psychological viewpoint: depressed, diminished energy, vitality's down, sense of well-being, and it has also impaired cognition and memory. We did a recent study with diabetes, and we actually put it in with poor controlled men that they improved their delayed verbal recall, which is in the mini-mental score, which is one of the key factors for diagnosis of dementia, improved it. So physical, decreased bone mineral density, reduced muscle mass, gynecomastia, anemia. Not many GPs will say, right, let's look at the testosterone level if we can't find a cause for anemia. Frailty, increased body mass, and fatigue. So this is the regulation of testosterone secretion. GnRH from the hypothalamus stimulates the pituitary in a pulsatile manner to produce LH-FSH. LH is responsible mainly for the production, synthesis and release of testosterone. FSH has a role, but is mainly in spermatogenesis. So LH is the key pituitary hormone. And looking back at the serum testosterone, it's made up of free testosterone, which has a half-life of 10 minutes in the bloodstream. It has to be replenished rapidly from the albumin-bound. That which is bound to sex hormone globulin is inactive. It's tightly bound. So these two constitute bioavailable testosterone, which can be measured in research, free or the combination of the two. So there are mathematical calculations. The other thing everyone should remember is that diurnal variation of testosterone. This is where the peaks between 6 to 8 in the morning and hits a nadir 6 to 8 in the evening. You only need testosterone levels up for about 4 to 6 hours in the day to produce an effect which works through the androgen receptor. The androgen receptor is present in every cell in the body, so it's not just a sex hormone, it is a health hormone. So there's no generally accepted lower limit of normal. So testosterone, so most of the guidelines say 12 nanomoles per litre below, they warrant a trial of testosterone replacement. So that's the key factor. If it's above 12, they are probably not hypogonadal, but there may be some caveats to that, which I won't go into. So this is the hypogonadal obesity adipocytopine hypothesis, which we put forward back in 2008. So you have adipose tissue, the visceral fat. It breaks down testosterone by aromatase to estrogen. So overweight people are more likely to have a higher estrogen level, and this lowers the testosterone. The fat also produces adipocytokines, TNF-alpha, IL-6, and leptin, which inhibit the hypothalamic pituitary axis, reducing LH pulse amplitude, also lowering testosterone. Estradiol has a similar action. But these cytokines also increase insulin resistance. So it's a bad. So we need to find somewhere to try and break this vicious circle. Weight loss is a possibility, but how many times do you need at least 10% weight loss to actually raise your testosterone 3 nanomoles per litre? This is not going to happen in a normal, healthy, normal clinical practice. In a diabetic clinic, you actually achieve 5% weight loss. It's marvelous. So what about the cytokines? So you've got inflammation, infection, injury, a lot of the diseases I've shown you, which affect monocytes and conversion to macrophages, which produce these IL-1, IL-6, TNF, and others, having this negative effect on the hypothalamic pituitary testicle axis, leading to low testosterone and symptoms. So this guy, Sir Charles Darwin, evolution by natural selection, survival of the fittest. Is this where we are with this problem? Illness. If you have flu, your testosterone level, the cytokines will suppress your testosterone, and you have no interest in sex, the man. So it's probably the fact acute is protecting the species, but the chronic disease also has that effect. So you get this suppression of the hypothalamic pituitary hormones. We were the first to show that testosterone therapy in men with cardiovascular disease actually inhibited TNF-alpha, and we've shown also it reduces in diabetics production within monocytes and macrophages. There was an effect of increasing IL-10, which is anti-atherogenic. So we had these two things, and the study only had 25 patients in it, so this effect on IL-1 beta, would say it's approaching significance. But since other people have shown the effects of cytokines on humans, but this is on different cell types. And you can see it's all down, 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 except for LPS-induced IL-10, and it goes up. So IL-10 is an anti-atherogenic, and all the others are positive. So we have this now, and it's been in this 2018. The American Diabetes Association Standards of Care 2025 recommendation in men with diabetes or pre-diabetes inquire about sexual health, low libido, ED. If symptoms and signs of hypogonadism are detected, then a morning serum testosterone level with the diurnal variation should be done. Testosterone replacement in men with symptomatic hypogonadism, including sexual function, well-being, muscle strength, and bone density. So they're advising it, and we were the first to show that in a big study in Europe that we could, with testosterone, reduce insulin resistance, which is the core defect. And this was followed by clamp studies which show this is the insulin resistance reduced, but the glucose disposal rate was increased using clamp studies. A big study in Australia was done giving men with pre-diabetes testosterone, 1,007 men. One group with lifestyle plus testosterone, the other group with just lifestyle and placebo. And what this showed is half those number of men who with pre-diabetes that would have gone through to develop full diabetes in a 2-year period. So coming to the end. So what we also see in registry studies, and this is quite dramatic, there's a study that follows men on testosterone now for up to 17 years. This is 11-year data, and you can see these are the controls who are patients with low testosterone who are not treated or for one reason or another, and the green is the T treated. So you see the Hormone IR going down, the HbA1c, the diabetic control test going down, BMI going down dramatically, and waist circumference going down. It takes time. You don't see much difference until 12 months because you get weight, fat loss, but you get muscle gain. So it neutralizes out. So it doesn't come under obesity drug. So I am going to go through. We have this in the BBC. Testosterone could prevent heart and diabetes death. And so quality of life is important. And testosterone gives back quality of life. I'll finish in a minute. And this is a study which is looking at a score of quality of life, and you see these were in poorly controlled diabetics, and you can see this improvement in the total score, but the sexual subscale, somatic, psychological, and libido all improve. It's quite dramatic, really. And we're doing this audit, which is a worldwide audit through the Associated British Clinical Diabetologists, and the AMS score is rapidly going down, and this is in normal real-world practice. The Traverse study is a big study done by the FDA, which shows that testosterone is safe in cardiovascular disease. They start to get a difference, and this was supposed to be a non-inferiority study. So that was positive. Testosterone affects vasodilatation, heart function, cardiac remodeling, anemia, improves exercise capacity. It does a lot of things which will help the heart. It has very little in the way of adverse effects if you replace it back to normal. But we now know from the Traverse study no adverse effects on major adverse cardiovascular events. There is no evidence that it causes prostate cancer. It does cause fertility, and people need to be aware of that. And it can, in some people, increase the hematocrit, but this can be managed. And the only real contraindications are untreated chronic heart failure, untreated sleep apnea, severe benign prostatic hypertrophy, no evidence of majority of venous thromboembolism. So in the conclusions, symptomatic testosterone deficiency is very common, especially with co-morbidities. Low testosterone is associated with increased mortality, and so this is testosterone falls with age due to comorbid disease. So I've been through all that, and improves quality of life, improves survival, important for insulin sensitivity, and reducing doses of insulin in men with diabetes, and has important other effects. So I shall leave it at that, and it's a very important hormone. Thank you. Sorry.